volunteer.
Yeah. Oh, awesome. That's cool.
That's what I do. So.
Oh, I think the wind farms are a great idea. What's the Wi-Fi? Just
Oh, it's just LifePro guest, all lowercase.
Life Pro
Guest.
Yes, all
Yeah,
one word.
all one word, all lowercase.
Thank you. Oh, my hotspot.
I love your shoes, by the way.
Oh, thank you.
Yeah,
My nephew got them for me.
Oh, nice. I want the exact same one.
You run the chapter for San Diego, right?
The care services department.
Okay.
I have a boss. We have an executive director.
Because I'm really new to this, so I was just going through your websites and
Oh, okay.
try to figure this out. My mother is, well, I think the best way to put it is being diagnosed with ALS.
Oh,
It's
no.
still not, I know, it's still not 100%, but it's pretty likely that it
That's
is.
what they're going.
Yeah. So I'm just educating myself. So I'm registered with the San Diego ALS chapter.
Oh, okay.
Yeah.
Did anybody call you yet?
Not yet, no.
That's a little scary.
Maybe I didn't leave a phone number. I can't remember now. Thank you very much.
Yeah, of course. I didn't make a whole pot of coffee this time, so I always end up dumping it
I
out.
know, I feel bad.
I know, don't
Don't make it. 'Cause-
I know, I would much rather do this than
Yeah.
no worries.
No worries.
No.
We're probably live. No mics are
Yeah,
on.
all the mics.
You're finally commuting.
Oh, okay, great. Perfect. No, just okay. Just when I hand you the mic, you do a self intro, okay? All right, cool. Do that. If I turn this mic on, it'll work. And then these are for the speakers. All right. Want to go ahead and turn the camera on?
Yeah,
Or is it
you're on.
already showing?
Yeah.
So good afternoon. Thank you for joining us for the November Care Services meeting here at LifePro Financial Services. We appreciate this beautiful conference room that provided and IT support. Our speakers are on the property. They're heading this way, so we'll get started here in just a minute. In the meantime, just a few reminders. The Walk to Defeat ALS was held a few weeks ago, but our walk season continues through January 31st. So some walk teams are still vying for different positions, so they have a few more months to get their donations in. Our holiday party open house at our chapter in Scripps Ranch is December 12th from 2 to 7. So please stop in and visit us on that Thursday. And we appreciate all the support here at LifePro. They're getting our speakers wired with their microphones, and it's all good. So Thank you for your patience, and we're going to get started here in just one moment.
I'm on. Is it working? I mean, is there a way to test?
Yeah, I think if the green light's on,
Green light's
we're
on?
good.
It's
yeah,
on.
It's not going to amplify a lot in the room. It's mostly for the camera.
Okay, perfect. Should we come up there? All right. Sorry we're late. Good to see you too. Oh, thank you so much.
That's great.
So are we going to stand? Is that how you want us?
Yeah, that's good.
So the camera's
Camera's
back
there.
there, and you're live
everybody.
right now.
All right, good. Well,
You
we
can
won't do anything embarrassing.
Self-introductions, and
Perfect.
there we go. I'll
Thank
let
you,
you go.
Keith. Sorry we're late,
No worries,
everyone.
no worries. It's all good.
So I'm Elizabeth Semenova. I'm the practice director for Dr. Bob's Practice Integrated MD Care.
Hi. Dr. Bob Uslander.
And we were invited here today to talk about, end-of-life options, and specifically medical aid in dying, and some of the nuances that we experience in supporting people with ALS through the medical aid in dying process. So as a sort of framework, I thought we would start with talking about the process, how we take people through it, how we support people, specific nuances that come up in supporting people with ALS, and then one of the key points that's come up that we were asked to talk about was how to facilitate conversations with family members and how to navigate that. So that was kind of the framework. And you want to start talking about the process, maybe?
Here's what there's. Just like,
Oh, perfect.
you're way back here.
In the back.
Want us to move up forward?
You're fine. You can't. You're welcome to.
Or do you,
The camera's way back there.
can the camera zoom?
No.
Got it. So we.
I mean,
But yeah, if you stand here, you might be bigger.
yeah, let's do that.
Let's do that. Because we don't have any notes that, we're.
Yeah, we don't need anything. Is that,
How about this?
is that good?
Sounds good. Well, it's wonderful to be in front of this amazing audience. Thank you for being here. So, this is we really appreciate being able to come out and speak and help people develop a better understanding of the options that are available. The medical community doesn't do a great job of helping people understand how they can have the most peaceful and empowered end of life. The medical community system does a good job of trying to prevent illness and trying to keep people alive. And at a certain point, when it feels like there isn't a lot more that can be done to help to keep people alive or to cure them, then the default position is to have people go into hospice. And it's sort of become the default position that when there is no more curative treatment, or when people need additional support, that hospice is the answer. And hospice is a highly valuable service. There are amazing people who work in the hospice field, but there are gaps that exist that a lot of people don't know about, and even people in the medical community don't know about them. So we have developed a model of practice that helps to fill those gaps, and we like to try to help prevent people from falling into those gaps, because once that happens, there's already been a fair amount of damage done and struggle and suffering, and it's important to us to help people see the reality so that they can make decisions and avoid some of that struggle. My background as an emergency physician for 25 years taught me that the system has a lot of gaps and holes, and I saw a lot of people dying very badly through that experience. Elizabeth's experience through social work and working in the hospice field has also shown her
All the gaps.
all the gaps.
Right. And especially, and I know we're kind of preaching to the choir, because people experiencing the progression of ALS, you guys are all very aware of those gaps. You're experiencing them already on a daily basis. And so you know that there are things that you need, things that you want, and a way of life that you deserve that it's hard to come by, because there's not a lot of support for it. So
Yeah, and there are frustrations along the way. There are gifts along the way. We recognize that. our model, we really take a different approach than most medical practices, in that we really try to we try to make sure that we're addressing the needs of the patient and the physical comfort, and trying to help identify resources and tools that will enhance that. But we also focus on the spirit, and I don't mean that that we are that we're coming in and preaching and praying, and it's not a religious focus, it's a spiritual focus. We understand that within each of us is a spirit that is not damaged, diseased, impaired by a physical condition. And that's the part of each individual that we try to connect with and tap into. And we try to help the families and the loved ones create an environment where that's the case as well. And so we're really focused on helping to support the loved ones and the families who are there as the team and the village, because no one else is, it's really, I mean, the ALS Association, there are organizations that are there to help support families. The medical system doesn't really offer a whole lot. And so we recognize that there's a lot of needs there as well.
And in defense of the medical community, we're in America. This is a topic everybody talks about, right? We all have our advance directives. We share with our families what our wishes are. Is that accurate or totally false?
So what does that mean in terms of end of life options, and like what we're talking about?
Yeah, I'm just trying to take you guys a little higher level backwards.
Yeah.
And just say, in our culture,
Right.
Yeah.
this is a difficult topic for people sometimes to talk about. Other people find it very natural and normal.
Right. For some people, it's party conversation. For some people, you can't drag it out until something happens and they're forced into the conversation.
Right.
Right?
And the impact of that, ultimately, is that you end up in position, having not explored what your values are, what's important to you, what your desires are, your goals and your wishes. You end up in positions that you could potentially have avoided, or at least prepared for, that you didn't because it was a little bit scary to talk about.
Right. Or an awkward position where you've made some decisions, you haven't told anybody else,
And nobody knows how to support you.
and then they're surprised.
Yeah.
And we're at the, it can get pretty awkward.
Mm-hmm.
Yeah.
Yeah. So feel free to,
Talk about that too.
yeah. Thank you.
Well, I think that there's no simple answer to that, but I think the key, and we talk about this because we meet with people regularly. Part of our day-to-day activity through our practice is to meet with people who are either are healthy and don't have any existing medical conditions, or they're early in the development of a condition, and they want to know how to protect themselves.
Right.
They want to know what documents they have to have in place. How do they make sure that their wishes will be not just known, but carried out, respected, and honored. And so the things that need to happen, it's imperative that you have people who will act on your behalf, who will advocate for you strongly if you can't speak for yourself. An advanced healthcare directive, which all of us should have, everybody over the age of 18 should have an advanced healthcare directive, but it also requires conversation about what goes into that, and making sure that whoever it is that will act on your behalf understands what you want and is willing to honor it and support you and fight for you. The advanced healthcare directive doesn't come into play until you cannot make decisions for yourself and communicate adequately for yourself. But it's critical to have an advanced healthcare directive that has your wishes clearly expressed, and that your healthcare agent who's identified in that understands what you want. The conversations have happened, and they've assured you that they will honor your request, even if it's difficult.
And it's important, too, to explore those things with as many professionals, guiding professionals, as you can. So if your doctors are open to having that conversation, that's a great place to start talking about what might happen, what you might encounter, and learning with yourself and your family members what you might want to put in place to align your path forward with your goals and wishes. And where there are people who can't find doctors or social workers or nurses or professionals to talk about those things with them, that's where we come in. That's sort of what our practice is built around, providing that for people who can't find it in the care team that they already encounter. Because some doctors are able and willing and some aren't, and some are familiar with the end processes and some aren't, and some are comfortable with options and some aren't. And so having resources to explore those options is an important part of knowing and finding out what you want and what you want to put in that documentation.
And one of the things that I'll just throw out for you guys, in our world, in the world, I suppose, of anybody who's getting a terminal diagnosis, is depending on how that's presented, can really affect the quality of life for the time that's remaining.
Absolutely.
Yes.
And what I think we're trying to avoid through conversation is don't be so fixated on the fourth quarter, last 2 minutes, that we forget to live between now and then.
Right.
And if we just focus on that, everything stops.
And having those conversations early on where you know what the options are helps to allow the focus to be in the present moment, so that you're not worried about or have in the back of your mind what's going to happen at the end, because you've already explored what could happen, what you want, and you know that in this day, in this moment, you're putting in place everything that's going to optimize your experience. So to that end, maybe we should talk about medical aid in dying as one of the options.
Sure. And I think I want to reiterate. I want to re-emphasize that point, because it's really critical. When someone is given a diagnosis of ALS, like a number of other conditions, they understand that eventually that is likely going to take their life. Something can happen in between. But they are given a diagnosis, and it's a universally fatal diagnosis. The time frame is unclear. I know that in our conversations with people who have been diagnosed with ALS at various stages, as soon as they receive that diagnosis, they're already going to that place. What's the end going to look like? How am I going to? Would I allow myself to be, to have a tracheostomy? Would I live the way Stephen Hawking did, or will I refuse some of those things at a certain point? So we know that those conversations, or at least the thoughts are happening. Whether the conversations are happening, kind of depends on the individual and their family dynamics. But what we found is when we allow the conversation to happen without judgment, without having any agenda as to how it unfolds, it's just 2 human beings, 3 human beings, 5 human beings, having a conversation about the reality of the situation, the circumstances. Then we can help present them with a number of different options and allow them to be informed and to regain a sense of control. And I think that's really empowering, and it can help to color the time that they have remaining, whether it's weeks, months, or years. Yeah. And that time, they take this information, they take this sense of understanding, and they kind of put it on a shelf. They don't need to think about it or sit with it every day. They understand, and they know that they will have a sense of control to a certain degree when so much else is sort of out of their control. So that's been really powerful.
And the peace of mind that gives them is
Right.
really off the
Invaluable.
charts.
So it can be really scary to step into that space, to be vulnerable and ask yourself, what is this really going to look like, and ask for guidance and support. That can be really scary. On the other side of the experience, it's ultimately extremely empowering, and it does bring a lot of peace of mind and comfort. Yeah.
So when we meet with people who are looking for information about, some people want to know what the end can look like. How can they have more control over? What are the options available? Our initial approach is to learn about that individual. Because until we understand who that person is, where they come from, who's part of their world, what's truly important to them, what they value, what are the most important things. Once we have all of that, then we have a framework with which to start the conversation, and that colors the conversation. Then we identify what their resources are, who's part of their team, what are the challenges that they're really facing, what are they open to, and a lot of time that creates this sense of a trusted relationship, a trusted connection, because we can't really be of value and service to people until they trust us.
True. Until
they know that we're truly here for them. It's about being of service in the way that they need us in that moment, and that's an interesting thing, and we've talked about this recently. When we have those conversations, when we're sitting across from that individual, many times, or their family members, many times they've tried to have these conversations, or they've tried to get information and kind of been thwarted, or it's been shut down, or it just hasn't gone the way they would have liked. At a certain point, they get it. They get that this is a different opportunity, and then we have the ability to really, truly, honestly, speak, and they open up, and their fears are expressed, and a lot of times there's tears. We go through a lot of tissue, but we help people to see that they have a couple different options if they choose that it's time, and they don't just have to go on hospice and be medicated to the point of unconsciousness if they get to that stage. The two options that we really help people explore further to see which, if either, is comfortable for them, are medical aid in dying, and we'll talk about that process, and voluntarily stopping eating and drinking, which is also a legal process that's available for anybody who feels that it's time for their life to come to an end. Do you want to talk a little bit about the voluntarily stopping eating and drinking, and then I can talk a little bit more about the
medical aid in dying?
Medical aid in dying?
Sure.
That sound good?
Sure. So voluntarily stopping eating and drinking is exactly what it sounds like. It's totally legal for someone to decide that they are going to stop taking in food and fluids and allow their body to naturally come to an end, and to stop functioning and come to an end. It's something that a lot of people don't talk about. It's not something that you can get a lot of doctors to explain, and a lot of people have misconceptions about the process, about what it's like, and it's something that sometimes brings up things with people that makes them a little bit uncomfortable. The idea of making a choice that would hasten the end of their life is part of that conversation. The idea of keeping yourself from being nourished with food and fluids is something that can be really uncomfortable. And so what we've observed with the people that we've supported through this process is that with the right support and guidance, it actually it can be a really beautiful process. It can be something that serves to meet people's goals and wishes and allows them the path that they otherwise wouldn't know how to help themselves unfold. So when someone decides to stop eating and drinking, and we're guiding them through the process, the way it works is for the first sort of 4 days, you're still as engaged and alert and oriented as you would be normally. You gradually start to weaken, but you're still conscious and having conversations and doing the same things that you would otherwise be doing for the first few days. And then as you start to weaken and drift into a bit more of a sleepy state, there's a few days where you're kind of in and out. And the first thing people say is often that they're very surprised they don't experience any discomfort from hunger. Maybe a few, they might notice that they're not eating, but that by the time people make this choice, they're often really comfortable and aligned with it, and their body responds to that. So they end up not really experiencing discomfort with hunger, which is one of the first concerns that we address. There is certainly thirst. The way that your body works is when it functions off of hydration. And so when you start to become dehydrated, your brain tells you you're thirsty in order to get you to drink water. And so thirst is basically your body saying, please hydrate me so that we can continue to function. And the way that, which can be uncomfortable. And so the way that we help mitigate that is by using little spray bottles to moisten the mucous membranes in the mouth, which effectively tricks the brain into thinking that you're hydrating your body, and then allows you to be more comfortable. There are also little sponges that help, or ice chips, small amounts of water to just help keep your mouth comfortable makes a big difference in that. So hunger and thirst and alertness for the first few days are the biggest kind of questions. And then you, again, drift into this sort of sleepiness and a little bit in and out space where you may still be lucid and present at times, but may also be kind of fading away a little bit in terms of your engagement with your loved ones and your environment. And then after another couple of days, you drift into a deeper state of sleep, which is effectively a coma. And that's where you stay as your body continues to shut down from dehydration. And ultimately, that would be the cause of death. You would pass away. The process typically takes about 2 weeks. Everybody's different. Sometimes it takes a few days. Sometimes it takes a little more than 2 weeks. But a good average is about 10 to 12 days. The idea of this experience, part of the reason some people are really interested in it is because medical aid in dying is a process that's legal by which someone can acquire medication to hasten the end of their life. Some people are really uncomfortable with that choice, and whether it's a religious or other reason, they're more comfortable with the idea of a natural progression. And the time that allows is also something that gives people, them and their families, space for completion and sort of sacred time together. Let's see what.
Well done.
Oh, thanks. There's
Yeah.
so much more.
There's so much more, but
Where next?
That's a great overview. And I think the one thing a couple things I'd like to reiterate and share is I've been very surprised at how comfortable this process has been for people, because I, like most physicians or people in the medical community, not that long ago, didn't know about voluntarily stopping eating and drinking as a viable option for somebody to have a peaceful, dignified end of life. Now that I've become more well-versed and knowledgeable and have had experience of supporting people through that, I've been time and time again a little surprised and really pleased at how comfortable it has been. And in some ways how transformational it's been for their families who are there loving them and supporting them through that process. I think it's also important to share that we never encourage people to take any particular path. We're not encouraging, influencing in any way. We are laying out information and giving people the truth about the different options, and if and when they choose to go down that path, then we are there committed at the highest level to support them and make sure that it's as struggle-free and supported and transformational as possible. You had a question?
Yeah, two questions on that process. Pain?
So
Anything to talk about there?
Yeah. There are people who are on medications, pain medications, because their underlying condition may be painful, and it's important to transition them to medications that will continue to manage and treat their pain effectively, but without having to take a lot of pills that require water
Well.
that would make this process take longer. Sometimes that means putting on patches. Sometimes it means a higher concentration of pain medication. But the transition of medications is one of the important things. The other, and the process itself is not painful. But people are given access to medication for anxiety to help them sleep better. As they get dehydrated, their bodies can stiffen a bit, their joints can stiffen, movement can become uncomfortable. And at that point, we're also being very careful about ensuring that they have medication available to alleviate that. And other comforting measures. We bring in massage therapists or energy workers or acupuncturists, whatever people are interested and open to, but we bring a team of integrative holistic therapists to add to the experience and help with the feelings of comfort and joy.
So the follow-up question on dehydration, the impact to risk for stroke or heart attack kind of goes off the charts. Any surprises have occurred, or is that like a non-issue?
Well, it becomes a non-issue because at the time when somebody gets dehydrated to the point where other consequences may unfold, they're already on this kind of far along on this journey, and they're often in a state of unconsciousness by that time, and we're just managing whatever symptoms come up. So I haven't seen anybody who I felt had a massive stroke or a heart attack in the midst of the process. It's, in our experience, has been fairly. Actually, I take that back. There was somebody who actually died 3 days into it, which was unexpected. And so there probably was some other underlying condition, probably not as a result of of extreme dehydration, because it hadn't even gone on that long.
Mm-hmm.
But things can happen. The other thing that we've noticed is that people tend to go along a little quicker when they're really at peace with their decision and truly ready, and they're given permission. Permission is a big thing in all of this. Individuals need to give themselves permission to make the choices that are most aligned with them, and family members and loved ones need to give permission and truly not just say the words, but truly believe it energetically. And when those things happen, people tend to drift away a bit more quickly and peacefully. So the other, voluntarily stopping eating and drinking is a conversation that often comes up when we're talking with ALS patients, because they may not qualify for medical aid in dying at the time these conversations begin. One of the reasons, well, I don't want to complicate it, I don't want to confuse things, so let me talk a little bit about the medical aid in dying so that we can lay that out and everyone has an understanding. Medical aid in dying is currently legal in 10 jurisdictions throughout the country, including Oregon was the first state, and it's been, I think we just had the 25th anniversary of the law passing in Oregon. Washington State, California, Colorado, New Jersey, Maine, Vermont,
Montana,
Washington, D.C.,
Hawaii.
And Montana has a law that doesn't disallow medical aid in dying, but it's a different process there. Most of the states have similar qualifications and laws. It requires that a patient be a resident of the state, be an adult, be competent to make decisions, and have a terminal illness that, if it runs its course, will likely end their life within 6 months. They have to make 2 requests of a physician, attending physician, face-to-face, alone, and request access to a prescription to end their life if they choose to take it. They make 1 request. The second request has to be made no sooner than 15 days from the first one, so there's a 15-day waiting period. And the other requirements are that a consulting physician who's independent of the attending physician also assess the patient and determine that they're competent, and that they have a terminal illness. And the patient has to sign a written request form and have it witnessed by two people. If either the attending physician or the consulting physician feel that the patient has a psychiatric illness or there's some psychiatric condition that is impairing their ability to make decisions, then they need to be referred to a psychiatrist or psychologist for an assessment. The patient has to be able to ingest the medication into their body somehow on their own. And that's an important point, especially when we're talking about patients with ALS who might have physical limitations. They either need to be able to drink it, and they can drink it from a glass, they can drink it through a straw. Somebody can hold the straw, the glass, and as long as they can drink it. The other options are people can, it can be given through a nasogastric tube or a gastric tube or even rectally, but the patient has to be able to push the medication through a syringe so that they are responsible for the medication entering their body somehow. Those are the requirements. A lot of nuances to it. So the areas that are sometimes questionable are the competency of the person. Are they able to make informed decisions? Do they understand the impact of their decisions and consequences? And the other area that can be questionable is the prognosis, the life expectancy. How do you know if a person has a life expectancy of 6 months or less? Often very difficult, especially in the case of ALS, because then you also have to consider, well, if the patient agrees to certain procedures, then their life expectancy could be a whole lot longer. If they're not willing to undergo a tracheostomy or a feeding tube, then their life expectancy will be shorter, but the progression, the speed of progression, the timing of progression can often be difficult to ascertain or predict. So those conversations are obviously critical. Learning about the nature of the condition, the extent of it, the pulmonary involvement, the involvement of the swallowing muscles, communication potentially with the neurologists to get their feedback. All of those things often come into play when we're evaluating patients with ALS who are asking for support through medical aid in dying.
Can I share how
Please.
it works? So how that works, what that process looks like when we take people through it, when we support people through it. It starts with the initial visit with Dr. Bob, which is the assessment kind of that he described before, where we get to know the person, we get to know their medical history, their circumstances, their condition, their resources, the gaps and challenges, and their goals and wishes. And then we have this whole conversation about all of the options. And if someone decides at that time that they want to initiate the medical aid in dying process, then that would be the time that they make that initial verbal request of Dr. Bob to get the medication that would allow them to end their life in a dignified manner. We follow up that conversation with review of medical records, communication with the treating physicians who are involved in the person's care so that the doctor can get a really good understanding of what the condition currently is and what the prognosis will be. And with that, then he determines whether or not they qualify. And if at the time they do, then we can move forward with the process. We can either have a consulting physician who's already engaged in the patient's care. So often the neurologist or other specialists or primary care doctor will be willing to serve in that capacity. Where they are not, that's fine. We can refer an independent doctor, so someone wouldn't have to go about finding their own second doctor, because that could be a nightmare. And then they have the written request form, which we provide and has to be signed and witnessed, and then the second visit with Dr. Bob, which completes the process and has to be, again, a minimum of 15 days later. So logistically, it's bookended by 2 visits with Dr. Bob and communications with a consulting physician and the written request. And those are the requirements. While we're supporting people through this process, part of what we offer is ongoing communication, support, guidance, and discernment about whether it's the right time, whether this is the right path, about bringing family members together and understanding about the patient and intimate family members' goals and wishes, about the path that's unfolding before them, and helping to facilitate understanding where there might be discord, helping to facilitate completion where there are relationships that need resolution, helping to ensure that everyone is on the same page so that there's again, most peace and comfort possible. And then once the process is complete, the person has the ability to get the medication, which I'll let you talk about.
Yeah, so once they've gone through the process and they have access to the prescription, then it's their choice of whether to have it filled or not. If they choose to get the medication, the prescription filled, they communicate directly with the pharmacy. The pharmacy, puts it all together and will deliver it to the patient or someone they designate. We are kind of unique in that we make ourselves available to be with the patient and family at the time they ingest the medication. The law, the End of Life Option Act, does not require that there be any medical personnel
or anyone at all.
Or anyone at all with the patient at the time that they ingest the medication. In our experience, it's clear that having somebody who understands the process, who is a trained medical professional with the family is invaluable and allows them to be focused on their loved one and be present and loving and supportive, rather than trying to figure out if everything is being mixed properly, or if something is normal or abnormal. There's just a sense of comfort and security of having experienced people on hand.
I'd like to speak to that too.
I'd love for you to speak on that.
So not only to have someone who can help with the logistics, but also most people haven't been with a loved one as they were dying before. That's not an experience that a lot of people have. And so having someone who has been through this, there, present with you at the time, really helps, in our experience, really helps people to integrate the whole process. And that can be really powerful for the bereavement process and healing ongoing after the loss. Being with someone you love as they are dying is a really powerful and impactful experience. Having someone there to guide you through it can be really powerfully impactful in a positive way as well. So although the law doesn't require it, we would certainly encourage it, just because of the positive outcomes we've seen from having been through that with people.
Yeah, in most of the cases, we're just sort of like in the background, in a corner, just letting them sort of be. But it's sort of like when you're on a plane and a little turbulence, you tend to look over at the flight attendant to see how he or she is responding, and if they're calm, then you're calm. Kind of the same thing. When this is happening, people are looking over. Was that like the way they're breathing, or is that pause, or is that normal? And so I'm able to help to just keep the tone calmer, just by helping them see that this is all normal, the normal part of this process. There are unique challenges to we've already alluded to some of them with respect to ALS patients and accessing medical aid in dying. Sometimes they have difficulty swallowing. Sometimes they have lost the ability to move any of their extremities. And not everyone will actually be able to follow through with this process. That's a reality. And I know that one of the things that comes up is this sense, if they do go through the process and get access to the medications, and they're seeing progressive changes, they worry that if they wait too long, they will lose the ability. They will no longer be able to swallow. They will no longer be able to push the medication into the tube. There's error around that, and so we recognize that there are times when people feel compelled to potentially move things along more quickly, so they don't lose the opportunity. And those are unique challenges that we try to sort of take one like individually, case by case, and do what we can to provide support. But of course, we are bound by legal the legalities of it, and so those challenges exist. We do everything possible to help mitigate them and help people understand how to move
Navigate
through
them. Yeah.
And wouldn't that be a benefit of having folks like you with the family? Because there's this uncle 3,000 miles away who's going to second guess everything that happened. And no, we followed the law to the letter. And it's, doesn't that provide a little comfort and cushion for the family?
Absolutely.
Okay.
Yeah, there's many different ways in which that comfort and benefit unfolds, and each time we're part of another scenario, we see even more deeply where those benefits come in, and it helps to reinforce that.
So having the medication, I've gone through the process, I'm fully approved, it's in the bathroom, behind the mirror. The latest statistics I found is about 67% of us don't actually take it. But the benefits of having been through the process and knowing it's there if I choose to are tremendous. So it seems like it's a healthy process whether you cross the bridge at the final end or not. Is that comments?
Yeah.
I think the statistics are, I'm not sure where you got the statistics. I actually, my research.
It's reversed?
It's reversed.
Mhm.
My understanding is that overall about 60 to 70% of people who get the prescription end up taking it.
Okay.
30-some% of people don't for various reasons. I think in our experience it's even a little higher. By the time people come to us, they've tried to find support and haven't been able to. Things are often a little bit further along. I think our statistics are probably a bit higher in the number of people who end up taking the medication, but it's not 100%. And the benefit to the patient actually begins from the first conversation. That's when they experience a certain sense of relief, and then they have access to people who are there for them at any time, day or night, to address their ongoing concerns and provide it. And that's one of the other benefits of having this law in place is people are having the conversations. Even if they don't qualify for medical aid in dying, they're opening up and they're discussing their fears and they're getting feedback about how they can have the most comfort, the most peace, and empowerment through the last phase of their life.
Quickly, just to answer that too. This is considered a palliative care option, so having this process available is considered something, a part of palliative care. It palliates an existential concern, and potentially, if you take the medication, the physical symptoms as well. But ultimately, it's the piece that comes from going through the process and knowing that you have this available is about serving that existential fear of suffering, of struggle, of what could be on the other side of the progression. Sorry.
So for our home audience, if all of us, I know we moved you closer.
Yeah.
Pretend I'm still 50 yards away.
Okay.
I got a YouTube, we're coming across pretty soft. So.
Okay.
And I'm going to let you.
Hi. Well, thanks for the presentation so far. It's been definitely very helpful for me. One question that you mentioned, to qualify for this, specialists should estimate 6 months of remaining life.
Right.
What if you qualify, you get the medication, and then you live beyond that? What happens if you pass the 6 month?
No one
Okay.
will come and take the medication away from you.
Okay.
You have the medication. I mean, some people fill the prescription and have the medication. Others leave the prescription in the pharmacy. After 6 months, the prescription would need to be renewed
Okay.
in the pharmacy, which would mean, in my case, I would have a follow-up with the patient
Right.
to make sure that they still are competent, because that they still have to qualify from that standpoint.
So the qualification process renews, but you have to go.
I don't have people go through the entire process
Okay.
again, unless something has changed substantially.
Right.
Unless they've had a significant change in improvement,
Mm-hmm.
which
Just
tends
happen.
not to happen in ALS. Sometimes people will stabilize and plateau,
Right.
but as far as I'm aware, there have been no advances in curing or improving
Yep.
the outcomes.
Okay.
So, good question.
And once the medication is yours, it's yours. Legally, the patient owns it, and nobody can take it from them.
Right. But they do get expired probably or need
Yeah,
renewal or
they
some
They lose
medicines.
potency
Right.
over time.
over
Yeah.
time.
Okay. Thank you.
You're welcome. There's a lot of nuances to this, and we have learned over time how to make sure that the patient and family don't find themselves in the midst of struggle. By the time people get to us, they've often experienced a fair amount of struggle and frustration and disappointment, and so it's really important to us to allow this once the process is underway and the patient qualifies and they have access to this legal option. We really like to make sure that they don't have any additional hiccups or blips along the way that are going to cause more struggle for them.
Well, like a year and a half ago when some judge shut it off, right?
Right.
For a period of time. That
Yeah.
was not a good experience for
Correct.
people.
We don't have any control over that.
Right.
But it did have a
Oh,
significant impact.
huge.
And so people still have an underlying sense of fear of whether this will be taken away from them, whether the option will still exist in the future. From my understanding, it seems like the law is relatively safe. The Supreme Court made a statement that they will not hear that case. There will be ongoing challenges, as there have been in other states. As of right now, it feels like it's pretty secure. And again, we don't encourage people. I never try to tell somebody this is the best option. I would never have that conversation. We understand that in many cases, this is the best of the bad options available for them. In many cases, there are no really good options, but there are better options than just allowing the natural progression to occur if that's not your choice, if that's not acceptable to you. We like to say that that we're helping people achieve a soft landing, right? People want a soft landing. They don't want to have to struggle at the end, and that's what this option provides. It gives people a sense of peace and security, and it gives them a soft landing. And interestingly, I also believe that it's a form of suicide prevention, because when people have access to this and they're otherwise struggling, there are many people who are looking for other ways out, and often they're more violent or uncertain and cause a lot of trauma and struggle in the families. This is a way to avoid having to go down that path. Other questions?
Health insurance, Scripps, Sharp, Kaiser, Medicare. Does it matter to you guys, or how does all that side of this work? How do you get paid?
So our practice is a private practice, private pay. So our services aren't billed to insurance.
Okay.
There are options. Medicare does not cover the medical aid in dying process because it's not a federally legal option. Medi-Cal does. So if someone is on Medi-Cal and their primary doctor is within Medi-Cal, then they can bill to Medi-Cal for this process, and the medication would be covered. Where people come to us and don't have the ability to pay the standard fees, we operate on a sliding scale anywhere from our standard fees down to zero. It just depends on what's available to them and comfortable, and what we're able to do. Kaiser has its own end-of-life option process in place, as does UCSD. Scripps does not. Hospices are hit or miss in terms of their level of participation and support.
So let's stop there for a second.
Yeah.
So as I'm interviewing potential hospice sources,
Yes.
kind of a topic you want to talk about, right?
Yes, that is
Yeah.
a really good point. So One of the things that's interesting about interviewing hospices is that they will often tell you what you want to hear and then provide kind of what they've told you they will offer. So or not. So where there are hospices that say we support your choice to pursue this option, that can mean anything from you're allowed to go and find a way to get this done, to we might give you a referral to resources to help you find a way to get this done, to someone on our team may or may not be willing to help you get this done. It's very rare that a hospice has an entire system set up to take people through this process, and I haven't seen it. I can't say that it's not possible that it exists, but I haven't seen any other hospice or any hospice take people through the process in the way, with the level of support and thoroughness that we do in terms of providing not just the 2 visits with the doctors and the medication, but the support to the family, the support to the patient, the discernment, the guidance, all of the things, including being present at the time of taking the medication. So getting kind of down to the nitty-gritty about when interviewing hospices is important. So not just saying, do you support medical aid in dying, but saying, do you have a doctor who will come be at bedside when I take the medication? Do you have, can you guarantee that my team will stay my team as I go through this process? There's a lot of nuances to that too. Regarding Kaiser and UCSD, they have processes set up that are covered by insurance. UCSD, you have to already be a UCSD patient in order to use their process. For Kaiser, there's a good system set up where someone is on Kaiser Hospice and they're in a zip code that Kaiser medical director is willing to support the process. Where someone is not on Kaiser Hospice and not in a zip code where their medical director is willing to support them, it's more burdensome. We can take people through the process in 15 days, get them the medication and have it all done in that short time frame. Where people are part of a system, that tends to extend because there are more hoops to jump through and complications, finding a doctor that's going to support them, revoking hospice, going to the clinic to get the appointment with the doctor, setting the appointment several weeks out, et cetera, et cetera. So they do definitely have support. They have a process and they have people who will take you through it. They'll figure it out with you. Some people don't want to go through the rigmarole and the hullabaloo that comes along with being part of that system. Right. And so we're able to help in a much more efficient and gentle and holistic way.
So would it be prudent, I'm kind of on this path, and I'm thinking about it, but I'm not sure. Sounds like I should probably start the process in case I'm in one of those scenarios where this is going to take months to get it set up. And then throughout that process, working with somebody like you guys, I'm probably going to formulate a decision one way or another. But stalling doesn't help. Is that kind of the, push, not talking about it, thinking I can do it real fast later, which is just simply not true. Thoughts?
Right.
Yeah.
So yes, that's absolutely correct. Stalling doesn't help
Anything.
Ignoring or pushing down the conversations. I think the best thing to do is to initiate the conversation and find out where you will get support. If you have a primary doctor, oncologist, cardiologist, neurologist who you have a good relationship with, that's where the conversation should start. If you don't feel that they're open to it or they shoot it down or you don't feel comfortable, then you need to look for that resource. We've become a resource because for that reason. There's a lot of people who can't find the support, and so the conversations are not available. So we're open to having an initial conversation with anybody with no obligation over the phone to give them to learn a little bit about what they're experiencing and help them understand the next steps that would be helpful for them. So that's sort of our initial consultation that we're open to having with anybody anywhere, because we understand how important it is for
have
someone to have that connection and be given that initial guidance and not feel like they have no idea where to turn. And at that point, then we can help them discern whether initiating that process makes sense, whether looking at some other. We also encourage people we advocate for people to get better care. We never want to be concerned that somebody is making this decision to end their life sooner because they couldn't get the care that they needed or deserved. So we often, when we feel that the care is inadequate, their pain management is inadequate, their support is inadequate, we look for other resources and we look to help guide them towards improved care so that they don't feel as desperate or as despondent.
So what I missed that I meant to mention, Veterans Administration. Where's the VA on this?
So the VA is a federal organization, and so they don't participate because, again, this is not a federally legal option. People who are part of the VA can go through this option outside of the VA, but they can't go through the option within the VA. Where there are physicians who are doctors at the VA but also have practices elsewhere, they may be able to support their patients through it. So I know, for example, of a neurologist who works at the VA and also at a local hospital system, and he was able to support a patient of his who was a veteran through this process. He served as the consulting physician, and we walked them through the whole thing.
So if I'm a veteran in San Diego, I call you guys.
Right. And also the veterans' homes will not allow veterans who live in the homes to take the medication there. And my understanding is if they learn that the patient is even engaging in the process, that they wouldn't let them stay there. I'm not willing to stake my life on that. But I believe that the veterans' homes are very unsupportive of this, and so people are also, if they're living at a nursing home or an assisted living community, there are places that have made it clear that they don't support medical aid in dying, and so people don't know what their level of support is, so they're very nervous, reticent to talk about it, especially people who want to keep it very private. But they're also concerned that it may not be supported, and they may be judged, or their care may change, or they may not be able to stay there in the final days. So lots of nuances to it, lots of issues that can come up. So on the one hand, I would like to see more physicians supporting their patients and helping them get through this process. But I also understand that without having experience and understanding what the potential gaps are and where people could get stuck or have things backfire, until you've been part of this a number of times, you don't know what to watch out for. And so we worry that if other physicians are just kind of casually supporting people through this, that it may not serve anyone well. So we're also we're being proactive about educating other healthcare providers, hospice agencies, communities, physicians about the ins and outs of this law so that they can best serve their patients.
So, and to that point, one thing that's really important is there are people who maybe have this conversation with their doctor, and the doctor says, well, I'd like to support you, but I really don't know how. I'm not comfortable. I'm not familiar with the law. I don't know what that would mean for me. I understand your choice, and I support your choice, but I don't know what to do with that. Where that has happened and people have found us, Dr. Bob has been able to guide the physician in understanding what their role would be, what their responsibility is, what the legal implications are. And often those doctors end up serving as the consulting physician. They often end up supporting their patients through this in whatever way they can without having to take on the whole process and the legal responsibility of being the prescribing physician. So it's really important to us that we be available as a resource not just to the patients and families, but to their providers as well who want to be supportive and don't know how.
Okay. Question from our live audience.
Live audience.
I actually have 3 questions. You mentioned a couple of times supporting the families as well. So the patient may be in a condition that they're like, you know what, I would like to finish this gracefully, but maybe the family is not ready for it.
Yeah.
How do you deal with that?
Yeah?
You take that one.
Okay. So fundamentally, the work that we do is based on the principle of personal autonomy of the patient first. It's patient-centered care. So if there's a patient who wants resources, information, and options, that is the guiding principle for our presence in the family system. Recognizing that there are loved ones, care providers, and others who are impacted by that differently, by the patient's experience and choices and wishes differently. Some people are reticent to lose their loved one, but supportive of the choice because they understand whatever it is that's guiding and motivating it. Some people are opposed to it and not sure how to navigate conversations where their loved one, maybe a spouse, wants to take the medication and they don't believe that it's okay. Whether it's moral, ethical, religious, or just a sense of discomfort guiding them. We, again, are principally guided by the patient and the patient's wishes and rights, and within the context of the family as a whole, help to facilitate understanding so that everyone can be heard and honored, and choices can be made collectively. It's really, optimal outcomes occur when conversations can be had. Where there is disagreement or misunderstanding, facilitating connection, communication, and understanding helps to bring about the optimal experience for everyone involved. Sometimes that doesn't necessarily, the results are different. Every case is different. Sometimes the patient decides not to take the medication because the family member really can't bear the idea of it. Sometimes the family member has a perspective shift and decides that it's okay for them to allow their loved one to take the medication. Sometimes the person takes the medicine and we provide support to the family member who still wasn't ready or comfortable. So my background is in social work and spiritual care, and part of what we offer is ongoing support and guidance, not just through this process, but in integrating the loss as well in bereavement care. And the more support you can have up front, the more comfortable the whole experience will be. That's why we talk about having a doctor present at the time of ingestion. That's why we talk about having conversations well in advance of getting to that final hour, because you're processing this experience together. You already are, whether you're talking about it or not, you're processing this experience together. And where it's hard for people to express themselves or even identify what it is that's important to them, we help support, guide, and facilitate those conversations so that the whole family can be as much at peace and in as much comfort as possible, always guided primarily by the patient's rights and wishes.
Thank you.
And I just want to add to that. You have 2 more questions.
Yeah, you can't
So
have your
I just
microphone
wanna
back.
quickly, briefly add to that. Our focus is on the patient and helping them have, get their needs met in a comfortable and dignified way. We're equally focused on the experience of the family and the loved ones when they allow us in, when they allow us to be part of that. And it doesn't always happen that way. But we recognize that the patient is gone, the patient is leaving, the loved ones are still here. And they will have a lifetime to process and to remember this experience, and how they remember it will color their life and their experience of life, their thoughts about end of life, for the relationships. So it's really it's critical for us to do what we can to allow loved ones to have the best possible outcomes. And often this medical aid in dying process, and also the voluntary stopping eating and drinking, when the families come together in support and feel like they've been supported, it allows them to go on with the belief that they gave their loved one a gift, that they gave them a gift, that it was things were done in the best possible way, and they will live with much fewer regrets and sense of guilt and a better experience of life. And we realize that, and it's really important.
Thank you. My other question was, you mentioned you start a conversation with the patient first to get a background and culture and all that. Do you provide your services in any other languages by any chance?
Spanish.
I speak Spanish.
Spanish, okay.
Yeah.
And so we haven't been asked to be able to provide service for people who didn't have somebody who was able to translate for them. If somebody's going through medical aid and dying, then we actually have to have an interpreter. It can't be a family member. There has to be an
Right.
actual official interpreter who's there and is part of the process. That's part of the legal process. And interestingly, we haven't had anybody who we couldn't speak
Communicate
enough
with.
English to get us through that process. What language are you?
Persian.
Persian.
Yeah,
There are translators around who would certainly be able
I'm
to.
sure. There's a big population around here. My last question, you mentioned UCSD having a service. Is that generally the UC system, or is it UCSD in specific, or UCLA or UC Irvine would have the same services?
I know that UCLA has a program as well. I don't know about UC Irvine. We see patients in Orange County who are part of UC Irvine. Haven't heard that they have a program like UC San Diego.
I believe they don't, largely because we've received multiple referrals from their neurology department, actually, for support and guidance through end-of-life options and medical aid in dying. And so if they had something in place, they probably wouldn't be sending people all the way down to San Diego to get guidance.
So it's not UC wide. And interestingly, UC San Diego, the people who work with the patients and care for the patients and guide them, wonderful. We know them and we collaborate with them. But neither the UCSD system or the Kaiser system makes arrangements for a physician or a trained person to be with the patient during the ingestion. That's a part that they haven't put into place.
There is actually no other, to my knowledge, there is no other physician who offers that. Hospices have hospice nurses. The hospices that participate have some nurses who are able to be at bedside sometimes. Sometimes they're able to be nearby and available, but not allowed to be at bedside. But there's, to my knowledge, no other physician who is available to be present when someone takes this medication, including the other doctors that guide people through this process in other locations privately, except for Dr. Shavelson in Berkeley.
I actually received a phone call from somebody, the daughter of a woman with ALS, a couple weeks ago.
Don't mention the name of the hospice.
I won't, I promise. Who the woman was on hospice and had actually gone through the medical aid and dying process with that hospice agency, and was given a prescription for the medication was prescribed, and they were getting ready to pick up the medication, but they didn't have any more information. They weren't given information about anybody being present with them, other information about what to do once they got the medication. So they actually got through the process and got access to the medication, but then they were sort of left on their own to try to figure out what to do, and they were terrified. So there are also some volunteers in throughout California. The End of Life Choices California is an organization that offers volunteers to talk with people about the process and help to provide some guidance. I also believe that they're available to be with people, and when they ingest the medication, they're not medically trained.
Some of them
they do
are.
have experience.
So there are 4 volunteers with End of Life Choices California. One of them is a naturopathic doctor. One of them is an
nurse
end of life nurse practitioner, retired. And I'm not sure the background of the other 2. They have someone in San Diego, someone in Palm Springs area, someone in Los Angeles, and someone in San Francisco. And there's a phone number and a website, End of Life Choices California. If you were interested, you could go to the website. Their phone number is there. They would also have a free consultation with you about options. And if you did go through the process and wanted someone present and didn't want to pay for a doctor, then they often are available to be present at the time of taking the medication and have supported people through it. They run into problems that we don't, though, as I actually was with one of their wonderful founding members recently, just last night, and there are obstacles that people encounter in this, like in Riverside. The regulations for the medical examiner's office are very specific, and if you don't know what to do in advance, then you can end up running into difficulty, and so they actually had an experience where the sheriff had to come and the coroner was involved, and that doesn't have to happen. It really doesn't have to happen.
It's very uncomfortable for families at the
Traumatic.
at that stage.
Yeah.
So those are some of the things that, until you have experience with it, you may not know where something might rear up and bite you.
Yeah.
You're
So,
welcome.
so you led us into my next question, almost.
Goody.
So I have decided that I want to exercise my rights and get the medication. I also want to donate my body to medical science or science cares, or even just my brain and spinal cord specifically for ALS. Have I messed that up?
Nope.
Or just speak to that if you could.
That's no problem. We've had people who have donated to Science Cares, UCSD body donation, and there was another brain donation. I don't remember the name of the organization that was involved.
So it's not non-issue.
It's a non-issue for those organizations.
So just to clear the air on that.
Yes.
It's not going to be a problem. And then again, if you've made those arrangements ahead of time, everybody knows about notification. I mean, sometimes you want to collect within 4 to 6 hours, and there's some compression of timing.
Different
on
body,
some of that.
Yeah, different body donation programs have different requirements or requests. And when you make those arrangements, they're very specific about what you need to do at the time of passing. When we're involved, we get that information in advance and make the calls. We've done it before. When hospice is involved, they have that information already, and they know what to do there too.
Okay, terrific.
A couple other things that just came up for me.
Sure.
There's so much.
There
There's
is.
so much.
Is life insurance is intact? Life insurance is not affected by this. Because the way the law was written, the cause of death on the death certificate is underlying illness. It does not have any impact on a person's life insurance, which is important. People do not need to be on hospice in order to take advantage of medical aid in dying. If hospice is appropriate for them and the additional support that comes along with hospice is beneficial, then it makes sense. I wouldn't have somebody go on hospice just because they were going to be doing medical aid in dying. That doesn't make sense. It's not necessary. However, if somebody is not on hospice when they ingest the medication, there needs to be a physician present to determine time of death and certify death has occurred. Otherwise, it will require that the police be called and paramedics come out and pronounce the person, which is a bit more of a ordeal. So hospice is not required. Sometimes it can help facilitate the services being delivered to the person in need, not necessary.
You don't have to answer this. Any comments about morphine and hospice, or don't go there?
Comments about whether it's used appropriately or
Whatever you want to feel comfortable talking about.
Morphine and hospice. So I'll make kind of some generalized comments about hospice care. And I think as I shared before, the default position in our country when somebody is in the final stages of life and the doctors don't feel that there's any more treatment that they can offer, or the person needs some additional support, the knee-jerk reflex standard course is to put them on hospice. And I believe that most doctors don't continue to care for the patient once they go on hospice. They're too busy. They're not necessarily trained in end-of-life care, and they don't necessarily want to be on call all the time for the hospice nurses who might have questions or needs anytime, day or night. So most of the time when a patient goes on hospice, they lose the relationship with the doctors who have been taking care of them, and they may or may not ever see a doctor once they go on hospice. Many hospices don't have doctors see patients. They may only be involved kind of peripherally. Some hospices actually have doctors who manage patients with the nursing staff, but that's a question that you might want to ask. If it's important to have a doctor involved in your care, you want to make sure that that's something that hospice offers. Many times, the care on hospice is hit or miss. This has been our experience, that there are people who are amazing, passionate, incredibly experienced, who will give the patient and family the absolute best. And then there are times when you have a brand new nurse, or an inexperienced nurse, or a burned out nurse. The whole range.
And sometimes within the same hospice company.
Correct.
Oh, for
Sometimes
sure.
within the
You
same
know,
day.
So everybody says, oh, this hospice source is the best. That doesn't mean the team you got
Exactly.
is that same group that they experienced. You've got to go with your intuition. You can fire these people.
Right.
You can switch. You're not locked in. And if you don't want to make that call, call me.
There
All
go.
you guys,
Yeah.
we'll help you.
Yeah.
Advocates. Hospice
Advocates.
wants to do a good job.
Yeah.
But not every hospice is created alike. There are, and most of it comes down from the leadership. But the point is, you have to have advocates. You have to recognize that things will not always go as ideally as you would want them to go, and you sometimes need to stand up and advocate for yourself or your loved ones, and sometimes find outside resources. And you guys are always there, ready to advocate for your patients. We're always available, ready to advocate for anybody who is not getting the level of care and service that they deserve. And we're not judging. We're not judging one hospice versus another, or trying to indicate that we do a better job, but because we are so intimately focused on each individual patient and their families, and our practice is small and intimate, and that's just our commitment, our model, things don't get missed, and there isn't the kind of the inconsistency that can often happen in the traditional models. We work with people who are on hospice to help add additional support on top of it, make sure they're getting the services that they deserve. We also work with people who are not on hospice. Sometimes we take care of people instead of hospice. And we also take care of people who aren't dying. We take care of people, well, we're all dying, but we take care of people who aren't dying anytime soon, providing palliative care, providing access to our integrative therapies, and the kind of personalized, intimate, person-centered spiritual care that we would want if we were needing to receive care. On that note,
Perfect.
That's it?
I think we will thank you so much
Thank
for your
you.
incredible insights.
For sure.
Okay.
Thank
So
you.
to get a hold of you, for those who are taking notes, and we'll put it on the YouTube address. Phone number, website.
Phone phone number is 858-925-7554.
Say it again slower.
858-925-7554. And again, anybody who's looking to have a conversation with one of us about your condition, your circumstances, and get some guidance for the next steps, we're happy to schedule a complimentary consultation call. Our website is integratedmdcare.com, integratedmdcare.com, and there's a lot of information about us and about our services and some testimonials from family members. There's a lot of good stuff on that. Some podcasts. We have a podcast an interview that I did with Bill Andrews, who was a local, well-known surfer who had ALS and went through medical aid and dying. And then we did a follow-up podcast interview with his 3 sons after they had helped him through this, one of whom became very actively involved with the ALS Association. So those are some really interesting interviews that I think people can find some real value in.
And Keith and Lindsay and Eric and your whole team, you know how to find us too. So if they're, anyone who's plugged in with Keith would be able to get you to us.
Thank you very much.
You're very
Excellent.
welcome.
Appreciate it.
Absolutely. Thank you for all your
Okay.
support.
Thank you.
So to our webcast audience, that concludes our care service meeting for this month. And thank you for joining us, and a big thank you to LifePro Financial Services for allowing us to use their conference room and be able to webcast this. Thank you.
Thank you, folks.
Yeah,
Okay.
for
Yeah,
sure.
thanks for being